start the afternoon off. I have my wonderful colleagues, Laura Marshall-Andrews and Shilpa Patel, both partners, and Laura is the GP partner who started Brighton Health Wellbeing Centre with Gary, Victoria, now practice manager. And Laura and Shilpa have both been cooking up lots of plans around the placebo effect. I know it's something which has been in documentaries and the news recently, and we are wanting to harness it for everybody's good health. And Laura and Shilpa are going to tell you what our plans are. There you go.
Thank you. So yeah, welcome. And Shilpa and I are just going to talk a bit about the placebo effect and how we're going to try to harness it as much as we can. So I first became really interested in the placebo effect after I read this article, which it's a very old article, and it was published in the Archives of Neurology and Psychiatry, and it was referenced in a book I was reading about compassionate care and the art of medicine. And basically this guy is a psychiatrist, and what he did was he was doing some work in India. And he managed to persuade, I think this was definitely before there were any ethics committees or anything like that, but he managed to persuade this prisoner who was condemned to death for stealing something. And he managed to persuade him, he was going to be condemned to death by hanging, that actually if he was, persuaded him to agree to be killed by exsanguination. So this was cutting wrists and bleeding to death. So what they did in this experiment was they blindfolded this man. He was lying on a bed, and they put 4 containers at each corner of the bed. He was lying there with his arms and legs like that. They blindfolded him. They then made very superficial incisions on over his radial arteries there and over his pedal arteries. They then had set up containers of liquids, and they dripped the liquids so it ran over his wrists and into these buckets. So he wasn't bleeding at all, but he felt like he was. And the psychiatrist then just sort of was talking to him and intoned to him in a kind of slowing manner. The liquid, as it was dropping, was initially quite quickly, and then it got slower and slower and slower, until it came to an end. And at that point, they noticed that the prisoner seemed to have passed out. When they went to examine him, he was dead, having not lost a single drop of blood, but his belief had killed him. And I remember reading that and just thinking, that's the most extraordinary thing to have happened, and what an enormous power our brain and our beliefs must have over our physiological processing in our body. And this is something which really, I think, underpins the basis of the placebo effect. So your belief in something has an actual demonstrable physiological effect on your body. And Shilpa's going to just talk us through some of the evidence and stuff around that.
Thank you. Okay, so my name is Shilpa Patel, and I've been working at the practice for about 3 years now. And the reason why I've got an interest in this area is because when I first came here, I was working on bringing people off of benzodiazepines and long-term medication that's not good for you. And I've had quite a lot of, I've done a lot of research into this area, and I've become very interested in trying to help people come off of medication, where I've been for 20 years giving out medication to people. I'm now doing the exact opposite and deprescribing, and it makes me feel really good to be able to do that at this practice. I was going to share a couple of cases that I've had good success with at this practice. One patient who was told that they would lose their children because they were addicted to diazepam, and she had been on diazepam for about 10 years, and she actually came to me after she'd heard about my work and asked me to help her, and it took about 8 or 9 months, but we managed to get her off her diazepam completely. She hadn't had her children for about 2 years at the time, and then one day she called me up and said, I've got my children back now because I haven't, and things like that have made me feel really, really good about the work I do here. So Laura asked me if I wanted to be involved in this project, and I straight away said, yeah, that would be amazing, because I have come to realize how bad medication is for you, and there's a lot of medication that does good, but if we can try and stay away from it, then I think that's a really good project to be involved in. So I'm going to speak to you about a couple of case studies and try and explain why I believe placebos work and why I believe they're better than medication. So I'm going to start off with, so there's lots and lots of research out there, and one of the cases that Laura brought up was an important one to her. This is my favourite one, and it was done in 1962, and they had a group of 13 Japanese children who have been diagnosed with extreme allergy to poison ivy, and they did this research to try and show that the placebo effect actually works. They brought all 13 children in, and they were given 2 different leaves. So on one arm they were given an ordinary leaf to rub on the arm, and on the other arm they were given a poison ivy leaf, but they were told the opposite. So all the children were given poison ivy but told that that was the normal one. And it's a really good experiment because you actually get a reaction if you're going to react to it. But because they were told the opposite, obviously all 13 developed a rash on the arm which had the ordinary leaf, because they believed, or they were told, they were convinced that that was poison ivy. And only 2 of the children developed a rash on the arm that was rubbed with poison ivy. So it just shows how belief, again, has such a big influence. And then there's actual physical changes that occur when taking the placebo. So I've done a lot of research now into what actually happens when you take a placebo. And if you've got that you've got to have the belief, but also there's a lot of chemical things going on in your brain. So as soon as you're told something happens, you do release kind of chemicals. And these are the kind of chemicals we're talking about. So in the case that I just went through, it's to do with histamines being released and that. Whereas a lot of research has shown that these are kind of the 4 type of chemicals that are being released. So you've got dopamine at the bottom there, which is a neurotransmitter. It's something that's released in the brain. And it's to do with, it's called a feel-good hormone. So you get feelings of euphoria, feelings of bliss, motivation, and concentration. So if you're told that you're being given an antidepressant, even though it isn't an antidepressant, because dopamine's being released, you start feeling good instantly because of that. So we don't actually know, if we're giving you an antidepressant, whether that antidepressant's actually releasing dopamine because of the way the drug works, or whether it's just dopamine that would naturally be released anyway. So you're feeling good anyway because of that. You've then got serotonin, which is related to dopamine. It's all to do with the feel-good factor as well. And it deals with how you process your emotions. So some of you might have heard of antidepressants that we use called SSRIs, and they work on the serotonin and they inhibit the action of it. And what we find is serotonin it's regulating social behavior, appetite, digestion, sleep, memory, and sexual desire and function. So so for example, the antidepressant that we give you for that, because serotonin also deals with sexual desire, one of the side effects of taking that antidepressant means that it affects your sexual desire as well, and that's why we get side effects, because it's not just working on the depression, it's working on all the other sides of it as well. You've got oxytocin, which I was finding out the names that they call it: cuddle hormone, love hormone, bonding hormone, happy hormone, empathy hormone, trust hormone, and there's a whole list, and I'll stop there because you get the idea of what it kind of does. It's even being tested as an anti-anxiety medication at the moment. So you can imagine if you're being given, even though it's a placebo tablet, and you're being told, and dopamine, serotonin, oxytocin's all being released, it makes you feel good automatically because of those chemicals. Oxytocin is something that gets released during childbirth, so that's just shows because you get high levels just before and just after, and that's why you get the bonding feeling with your baby, and it's that whole intimacy feeling that you get with that. And then one of the most important is the endorphins, or some people call dolphins, going around your head. And that's another feel-good hormone that's released during the placebo effect. And the important thing with endorphins is it's pain-related. So if you're given a tablet and we tell you this is for pain, those endorphins are released and they actually work on the pain receptors and they can take away that pain. So it's not, just, oh yeah, something's happened. There are actually chemicals being released during that effect. Another study that I came across as well is one that was done where they looked at all the different antidepressants, the main antidepressants that were used in America at the time, and they did like a drug versus placebo trial. And this guy, Irvin Kirsch, he looked at kind of all the trials that had been done and looked at all the results from that, and only some of it got released to get the drugs approved, and obviously some of it gets held back. And this is kind of a summary of what he found from looking at all the different trials that have been done to get these medications approved. They use something called a Hamilton score, or like a scale of diagnosis, to measure how bad your depression is. And what they found was, when you take the drug, on average, all these drugs that were approved by the FDA, when you take the drug, it was bringing it down by about 10.13 points on this Hamilton scale. But what they didn't show was that the placebo was bringing it down by 8 points anyway. So the amount that the drug was actually bringing it down above a placebo is only that 1.8 points. So 82% of the effect is happening just from that placebo, and it might not be working as well as the drug, but at least you're not getting all those side effects with it. So, and then I wanted to talk to you about, obviously, why a placebo would be better than taking an antidepressant, for instance. Like I said, because serotonin is released and it works on so many different areas, if you're inhibiting that serotonin, you're getting all these different side effects: dry mouth, weight gain, insomnia. You get the whole problem of withdrawal symptoms, not being able to come off the medication. With hypertension medication, you've got the dizziness. With painkillers, they go through the kidneys or livers, and they can damage the livers and kidneys long term. You've got weight problems, you've got stomach problems, drowsiness. So we're all familiar with the whole list of side effects that are listed on medications. And the main difference is the side effect of placebos. There is no side effect. And so if we can treat that same condition using this placebo effect, it's a no-brainer.
I wonder if people would sort of experience inside? Do you know what I mean? If you go into it, are people going to go into it knowing they're taking a placebo?
So the trial that, well, I think Laura's going to talk about that now. So Laura's going to take over and explain exactly what we're doing in the trial. Questions later.
So there is a placebo effect that exists in every medication. And as Shilpa just showed in this one, normally when you do a trial, you have this kind of effect. So you have the placebo effect and then you have the drug effect. And for ages, the placebo effect was just seen by us doctors as this really irritating thing that got in the way of proving how a drug worked. And it was really annoying if it didn't work any better than the placebo or if the placebo worked better. And it's only really recently that we've started to think about, well, what is the placebo effect, and shouldn't that be what we're really spending our time looking at? And I was actually talking to Liz that really made me start to think about that. So an awful lot of trials, which are usually discarded and not published by drug companies, the drug actually is no better than the placebo. And so over the last kind of 5 years, there have been more and more studies done into the placebo effect, and not just into, can we use it for different things, but also into looking at how we can enhance the placebo effect. And one of the studies they did actually in the UK recently was they looked at going into the doctor, and they had two different doctors. One had a student badge and was an actor, but was sort of slightly incompetent and didn't look like they didn't really know what they were doing. And the other one was a little bit older and had a badge that said professor and appeared very, very competent. And they rubbed it was again a cream onto their arms. They told them that it was an abrasive cream and that it would cause a reaction. And in the student one, hardly anyone came up with a reaction. But in the one that was applied by the professor, 93% of people came up with this reaction. So very similar to the Japanese children there. So the placebo effect exists, but there is also the capacity to enhance the placebo effect of any drug that you're taking. So for things like, if you have cancer and you're going to be prescribed chemotherapy or something like that, I wouldn't for a single second suggest that you don't take the chemotherapy because it will be doing something, and particularly in things like that, the risk of it not working is so high. But as doctors, what we can really look at, and what you can all look at as well, is how we can boost the effectivity of that drug by the placebo effect. So the manner that it's delivered in by someone who's spent time developing a relationship with you, that you trust, that you believe in, it's likely to make that drug far more powerful than it was before. So if we just go back, so we can look at enhancing it so that then maybe you can reduce the dose of the drug and you're still having the same activity because the placebo effect is higher. What Shilpa and I are aiming to do is to try and do a clinic here where we are looking at giving people a placebo, but because of the ethics and stuff, we would have to tell them that it was a placebo. Now the question is, would a placebo still work, as Lily said, if you know it's a placebo? And the answer to that question, and there have been 3 or 4, I think, quite good quality trials now, haven't there? This was one of the first ones, and there was a very dramatic one on patients with IBS as well. Shows that yes, it does, and it still works very, very powerfully. This one was about looking at patients with depression and doing the PHQ-9 score, and again the PHQ-9 scores came down very dramatically when they knew it was a placebo. So we're going to be starting a placebo clinic for people with mild depression and pain, and looking to sort of see whether in fact that helps. We've got a list of about 10 patients who are already interested in it. So if anyone wants to volunteer.
Are you going to give them something like an actual Smartie? Do you see what I'm
Yeah.
saying? So
Yeah.
that they'll be taking something
Yeah.
orally, whatever.
Yeah, exactly.
They're just told it's a placebo.
Yeah.
Thank you.
So, and it'll be
It's a
bottled.
sugar pill.
Yeah. It's rice powder. It's it'll
We've
be
done quite a lot of research
Yeah.
into the exact type of
Shape.
tablet that would work, the shape,
Yeah.
the colour.
so
and
blue
we're-
and white,
It's
isn't
a
it? Blue and white capsules.
You'll be given a prescription. You go to the pharmacy, you pick it up from your pharmacy, they give it to you, they counsel you. So it's following the same, exact same procedure that you'd have when getting an antidepressant or a blood pressure tablet or a painkiller. And we'd make you take it 2-3 times a day, 4 times a day, whatever the recommended dose is for that particular one.
Does anybody then report side effect? I know you can't, because
Yeah.
there's no list, but I mean, if it is affecting you physiologically, you expect, wouldn't you? If it, you know, like white coat hypertension, when patients come and say, oh, my blood pressure always goes up when I go to the GP, that's a definite physiological response, isn't it?
Yeah.
So if you're getting all these other things, so the rash,
Yeah.
producing histamine, that's, do you know what I mean? It's
But
all side effects.
if we can make you believe that you're not
Just
going,
focus on
that
the
it's going to
positives,
work, and we're trying to kind of use that positivity and that
because
kind
in
of
theory there should be no side effects.
Yeah.
So what you sometimes do when you're counselling patients, you end up with such a list of side effects.
and they read
before
the
you've even
list.
started.
They read the
So
list.
they've already
and
got
they-
half them
and
before
they
they've even
should.
taken
Yeah.
medication.
Yeah.
So you've got half of them because you're anxious before
Yeah.
you've started, and
Yeah.
you know you're going to get.
So that whole consultation bit is the really important bit, which is what we've realised. We've got to convince the patient that this is going to be the best thing for them.
You mentioned chemotherapy and the, you know, obviously to take that, or you said to take that. So with the children with the allergy, certainly one was in the media, the girl that died after the Pret-a-Manger thing, I can't remember what her name, sesame seeds I think was her allergy. And then I'm very aware of one that was here in Brighton, it was a few years ago, a chap was his 21st birthday, somebody made him a cake and put nuts in it but didn't tell him, and he actually died there, you know, had anaphylaxis. So people that have that tend to have EpiPens, so would you be saying that could go down the placebo route?
So could you get an anaphylactic reaction to a placebo?
No, I was saying, so would you advise somebody not to carry an EpiPen if they've got a diagnosed allergy that could cause anaphylaxis?
No.
No.
So no, exactly. So I mean, I think there are undoubtedly.
I carry an EpiPen.
Yeah.
Don't throw it
Yeah.
on the I've had it since birth, so.
Yeah. No. So I mean, I think that what I'm not saying. So I did this, had a sort of talk like this with a load of doctors, and they were sort of all saying, oh no, but you're going to be telling patients not to take their, that you can cure your cancer with your mind and that sort of thing, and that's absolutely not what we're saying. It may be that in 50 years time or 100 years time we look back and we think, God, wasn't it barbaric that we ever did surgery or treated anybody with anything, and that actually we can mobilize your immune system and all of these deep kind of hormones and things that we now are kind of trying to manipulate medically, just through the power of your brain. But at the moment we've absolutely no idea how to do that, so we can't do that. You have the best chance you have of surviving or dealing with it is through normal medicine. But it's just, I think this is like the tip of the iceberg where we are just starting to say, well, are there some things that we can just really try and use this effect to our advantage? And we've just picked a couple of things here that we think might be able to help.
And the areas we're going to be looking at are depression and pain and hypertension.
And hypertension, so and then we're looking at sort of mild,
mild
things like
hypertension.
that,
So we're very specific on the patients that we're going to accept onto the trial.
There was one amazing study as well that I looked at, which was where they looked at people were told they had 2 milkshakes. They were told that one of them was a really indulgent, high-fat luxury sort of milkshake, and the other one was a skinny milkshake. And people who they were actually both exactly the same. And the people who drank the high-fat one released higher levels of lectin, which deposits fat, so they actually put on more weight than the people that did. So it's bizarre, the power of suggestion. So all those things where they're actually, it's low fat, but they're telling you it's still really luxurious and lovely, probably are going against themselves, and they should say this is really horrible and very low fat, and you're going to get really skinny if you know. But yeah.
I just wanted to say it's interesting that the things we're looking at maybe to first try are seeing two conditions that the person's psychological state has a very big influence on those physiological reactions, so pain, depression and stress, I imagine, hypertension. And I read a really interesting article where they were actually doing placebo surgeries for Parkinson's. I think it might have been National Geographic or something that did this, Power of Faith or something, which we have to be careful when we get into it, but that actually there were very good results for opening up people's skulls, pretending that they'd gone into the centre of the brain, and they were getting some really good results after that for people.
From believing that you're better.
That you'd had some sort of thing done to you that will fix you. I don't want to interrupt too much, but I think again for CAM therapy, so a lot of the stuff that you guys do here, I'm a massage therapist. I don't even think we'll be using the word placebo in 10 years from now, because that almost deregulates. It's so important, that therapeutic alliance, feeling heard, feeling
I think that's it, and I think that it isn't either the placebo or a medication. The placebo is part of everything, and we've just sort of, so this is the time for discussion. So, but the conversation we've just been having about social prescribing and communities and stuff is really all about that, and the power of, or the damage to people from isolation and loneliness and low mood, and how that affects your whole body, your physiology. And it's isolation and loneliness is a big risk factor for all kinds of morbidity and mortality. So, which is sort of the same. If you're looking at actually people's connections and beliefs and feelings of well-being and empowerment, those are really important medicines.
I think all medicine has a placebo effect, and always has.
That's right. Any other questions?
You said, because SSRIs tend to be for depression. I don't know about hypertension, and I'll be a friend of mine. What drugs do people take for pain? Is it tramadol and that type of thing?
Yes. So the big thing at the moment is about opiate use in pain.
Is that tramadol?
Yeah. So tramadol is an opiate. Yeah, they're all derivatives of, initially of opium. Sorry? Lustrol is an SSRI, yeah. So SSRIs inhibit the reuptake of serotonin, so they increase the availability of serotonin in the brain.
Just the Parkinson one, I can't think of the name,
Dopamine, they give L-dopamine. So dopamine is also your decision-making hormone. So one of the reasons that Parkinson's get sort of tremors and they freeze is because dopamine is one of the hormones that makes you decide things. So if you overtreat someone with Parkinson's, they can become impulsive, they can become gamblers and things like that, because it affects their psyche.
Gabapentin, they use that for pain, even though that's epilepsy, is that right?
Yeah, so that works on the GABA receptors in the brain, and that's another neurotransmitter.
So we'd be using that for placebo, people are taking that. I don't take it, I know
we could do, so it would be in the sort of pain, in the realm of pain, yeah. So the other things that you could be using are things like gabapentin, and then ibuprofen, paracetamol. We still don't really know how paracetamol works,
really?
No.
Yeah. 25p or something.
Yeah.
Isn't that amazing?
They've already done research on the dopamine. There was a big trial done on Parkinson's patients, where they were told that they were being given a form of dopamine injection, and versus patients who weren't given, and that's another successful trial as well, where they showed that the placebo worked on Parkinsonian symptoms. But there's so much research out there that's actually proven what we're, when you look into it, they've done it in kind of every area.
Given that what we've just talked about, we've agreed that the therapeutic relationship with the patient, the importance of that and of having a consultation. When you're doing this trial, how long is your consultation with the patient? Is it different length to a normal GP consultation?
No, I think we'd try and do it just as the same. Right. Yeah. Otherwise, it skews it. Yeah. I mean, and this isn't, so we haven't gone through ethics. I mean, we've spoken to one of the ethics professors at the university who's basically sort of said it's fine to go ahead. If we wanted to give people a placebo when they thought it was something else, we'd have to go through the whole sort of ethics of that and do a proper trial, but that takes years to set up. So we just wanted to try and do a little pilot really here. So we would try and keep it as the same as everything.
I was just going to say, we do have to be careful about the evaluating research, because not all research is created equal, as you're aware. And for small group sizes, particularly the Jaguar chat, that was a very long time. It's very, very compelling, but we'd have to really kind of know that man wasn't ill or wasn't already on his deathbed. And even in the Japanese one, we have to be careful of caveats, like in Japan, children are conditioned to be very, very eager to please. And that could increase the efficacy of the placebo effect, whereas in another group, maybe not. But
I think that's absolutely right, and if you're more sceptical about things, then, and I think probably as GPs we kind of, we sort of feel that anyway. If you've got a patient who is more sceptical about a treatment, they're less likely to respond well to it, and they're more likely to, the patients who are going to get side effects. They've sort of already, So it does. There is that your belief system is just incredibly important.
So I wanted to say paracetamol. I was reading about this the other day, and I don't know if this sort of rings a bell, but we have sensors, threat sensors in our neurons, our nerve fibres, and when there's a stimulus, either heat, chemical or mechanical, there's some sodium ions, and the sensor will open. And what paracetamol does is it tends to try and close those receptors. But would that happen? Would we see a closing of the mechanical? I'm not saying this very well. The sensor with placebo, I would err on the side that we probably would.
Yeah.
Because if you believe that you've had a paracetamol, do those nerve receptors close up as well?
We just talked about this a couple of weeks ago, because I wasn't feeling very well, and I always take 2 paracetamols when when you just get to that point where that okay, I just need 2 paracetamols and I'll be fine. And I took 2 paracetamols. I came in the next day and I said to Laura, "You won't believe what happened yesterday." I took the 2 paracetamols and I put them by my dinner plate, because I thought, I'll take them with my water and whatever. And I thought I had taken it, and we had a meal, families all chatting away, and I was like, oh my God, I feel so much better now. And then I was clearing the table and the 2 tablets were under my plate. And I came in and went, "Laura, you won't believe I experienced the placebo effect yesterday."
That's when you book the doctor's appointment, but by the time you get there, you're actually feeling 10 times better anyway. The act of agency, taking some action, is often positive rather than just suffering.
Yeah, no, it's incredible.
But I think you're right. You've got to believe in it. You've got to have that, and that's what our challenge is going to be. We've got to make people understand.
Patient though, I'm just saying, if they don't, I don't mean it in a negative way, but if you turn it on its head, and so I was in that trial, and I had made the decision, I think it's a madness, or whatever I did. So that's another side of it, you're flipping it around, so do you then, I don't know, do you see what I'm sort of saying? Because we have lived in a pill society probably most of my life, get a prescription. We talk about it a lot, and I'm just wondering how, because we can be sceptical about politicians, say, and we can be sceptical about all sorts of things, and foods. And
Exactly, and there's only going to be a small amount of people at this stage. I would suggest who are going to.
Because if you've got a sceptical type of
Yeah.
personality.
Yeah, we could just say, well, that's your fault then.
Yeah.
No.
Flip it around to make somehow it work. It would be, it would save
Yeah.
a lot.
But
and
that's why
wouldn't have
these
many-
studies
Yeah.
are
Yeah.
the most compelling, because if you explain to a person
Oh, yeah.
and you address their scepticism, I think fault, it's never useful to talk about fault in healthcare. It's not
No.
your
I
fault
wouldn't
if you
think
get
of the right
cancer, it's not
words,
your
so-
fault if
No.
a pill doesn't work for you, or even if it does, sometimes it's so complex, a lot of it is down to
Yeah.
Yeah, I
a
wouldn't think
multitude
of the right
of things we
words.
can't measure.
That's right, and so the patients that we have spoken to about this have all been patients who are really interested in it and have bought into the concept of the power of their belief and have found it sort of empowering to think that they might be able to do something about it. So yeah, it will be interesting. We'll have to just we'll run each case, and it's not going to prove anything really, but it might make it, as pilots do, then it's something that people can then go on and build on and maybe do a bigger and more.
Would you maybe try to see if other health practitioners would be interested in, because
Or if the university would like to do a bigger research trial.
So I think with back pain, there's a couple of things in America where various clinicians all contribute to a kind of national database.
Yeah.
And obviously that's quite a big goal, but
Yes.
if there was something that people could, fitting within the same parameters, using the same kind of framework, could we start to build a bigger...
Just one question, Laura. The normal placebo trials, we know, there's a sugar pill and there's the real drug. What you're going to do is something totally transparent, and you're even going to tell the patient, which I think is mind-blowing, to see what comes out of that later on. Are you going to put your results with other people, or is it just going to be you starting or rolling, or?
Yeah, so I mean, we would obviously we'll document it, and we'll keep a record of what is done, and we'll do the PHQ-9 scores or the pain scores and things like that, and just see. But I mean, I would hope that we would then be able to take it to the university and just see whether they would then like to commission, we'd get someone to fund a proper trial, because trials need a lot of money really if you're going to do it properly.
But that is thinking outside the box. That's why I like it, because the placebo effect, we know. We've read about the Whittingstall did a BBC thing, I think, recently.
When he did the placebo surgery.
Yeah, but this is the opposite, isn't it?
Yeah. Well, it's taking it, this, and I think that these sort of 3 or 4 studies that we were looking at really showed that it is possible. So we'll see.
Yeah.
People on the trial, I think you said 10, have you sort of discussed at all with them, or, I mean, they put themselves forward, but do some say, I'll give it a go, but I'm sceptical, or have they, has that conversation not?
I mean, most of the time, at this stage, they're just people who have shown an interest in it. So we'll try and sort of get a few more people, and then we'll just start doing it, and then we'll offer it to people as an option, and see where we go.
How can you, with the placebo, with the pill that they're taking, can you also look at other factors that may be influencing them getting better? So, like your complementary therapies that you have here, so there may be some of them are having complementary therapies, or maybe they're doing things in their lives which are also helping. So how do you differentiate between the impact that the placebo pill is having, and other things that other factors are happening in their life at that moment in time?
Yeah, well, that's one of the problems that you have with trialling any medicine, and that's so. For example, if you were giving someone ramipril when they do big trials on antihypertensives, you have the same problem. You don't know whether it's actually because half of them are running more, or probably, but that's why you trial it against a placebo, and you have enough people that it should counter against a few of them doing something else. So trials that have power are trials where there's many thousands of people, so that it irons out any of those sort of issues. So obviously if we only had you know, a few people, and they were all coming and having acupuncture with Liz as well, and it, you know, it makes it's more confounding, and it makes it harder to see whether there is an actual thing there or not. But it's enough to give you an idea, and then if you want to go on and do the bigger sort of trials with thousands of people, then those are the kind of trials that they cost a lot of money. They need a lot of setting up, and that's not something that we could do here.
It's not going to be something that the pharmaceutical industry are going to be that keen.
No, exactly. Yeah.
Just another question, I guess, a bit linked to what the gentleman quite was saying. So, with all of those conditions, so hypertension and pain and depression, especially at the milder end of the spectrum, you'd always counsel some kind of lifestyle advice with it anyway. So presumably these patients are ones where that hasn't been enough, or where the next step would be to add in a medication. So it wouldn't be the first option, because then you're not.
There are a whole range actually. In fact, the majority of them are people who have been through so different antidepressants, come off and on them before. Nothing's really making a sustained kind of no. But it could be, you know, and I think I wouldn't sort of stipulate that it has to be that at the moment. I think we'll just sort of go through it and see, and we'll just try and collect as much data as we can, and then see if we do see any patterns.
So I think right now what we're trying to find people who would be interested, and you know, they could be at any stage, they could be, or they, because normally we give people options for, you know, when we're treating them for anything. So you've got different antidepressants you can go on, or different painkillers, and then this will be one of the options that, you know, if you're interested. And that's how I got a couple of the patients that I found. We were going through different options, and she was worried about side effects and things like that. And then I brought up the placebo, and she was she wasn't convinced at all in the beginning, and she was, you know, what do you mean you're talking about, you know, and then by the end of the consultation she was like, do you know what, I'd like to try, because she was just worried about taking a medication, and she said, you know, something like this would mean that, and so I think we're going to have a whole range, different types of patients, which we do with the medications anyway, and different people do different things on the side, and you know, and some people just take the medication, and some people do make improvements in their lives, and so if we see the whole range, then we're going to cover kind of all the different types of patients.
I was just going to ask a quick question. Do you have an idea of what kind of numbers you're hoping for?
No, not really. I mean, it would be nice to
Just keep going.
Yeah, it would be nice to kind of start with about 40 or 50. So I think we've got 12 at the moment, and we'll try and sort of build up till we've got that amount.
It's very new at the moment. We've
and then we'll just keep
wanted
going.
to start it straight after Christmas, didn't we? And then we've been busy with this, and so we'll get going with it.
How long do you plan to run it for when you get the group together, or you know, the numbers that you?
I think we'll just keep going with it and see how it's working. You know, if it comes back and everyone gets horrible side effects and doesn't get any better, then we'll stop it. But I doubt that will happen. So yeah, we'll just keep going and see. And I think it's a real just experimental thing, just to see. And you know, we've sort of discussed it, as I said, with the ethics kind of professors and stuff. And you know, we'll be aiming to obviously not do any harm, but just to see whether, you know, there's something that can help people that is better than what we have at the moment.
So fascinating, really enjoying this, thank you. I'm really interested in, it's probably a whole different study, but comparing sort of medical placebos taking the pill to sort of cultural placebos as well, and like the role of ritual and you know, different practices in how that can influence.
Absolutely, religious things, and
because even the act of, especially like with difficult emotions, and they say, you know, to write it on a piece of paper and burn it, and that feels a bit going further on, exploring how you can, you know, illustrate experiences and change them.
You could argue that pill taking is a ritual.
Absolutely.
No, exactly, that's what they think, is that the reason that it works when it's a pill is that it's linked, that a lot of the hormones and the physiological changes happen as a result of taking the action of, you know, the regular time in the day, the belief that something's happening as you're taking it, that it is actually linked to the physical thing.
I wonder if it starts kicking in just before it's still taking, so it's
Oh,
like, oh, I've got to go and do this.
Yeah.
There's a really fascinating documentary called Crazy Wise, which is like an anthropological study on psychosis, and they look at the cross-cultural responses to it, and they go to this shamanic community in Mongolia, and they look at how like people that are presenting similar psychotic symptoms are managed within the community, and the shamans go, well, like, you're one of us, so we're going to show you, you know, how to sort of harness the skill and, you know, channel it in a way that's beneficial for the community. And so psychosis technically doesn't exist there, and just how, you know, it's how experiences are shaped and framed.
Exactly.
Yeah. Is that Crazy Wise?
Yeah.
Brilliant. Thank you. Thank you all for coming.